Good afternoon, everybody, and welcome to the Sydney Vietnam Initiative webinar, which is entitled The Path Out of COVID-19, Lessons from Vietnam, Australia and Beyond. I'm pleased to welcome a distinguished panel of guests with us to go and discuss the really important and topical challenges around the COVID-19 response. Both of our countries have been affected very significantly in 2021. And we're going to learn today about some of those challenges, some of the ways in which our two countries are sharing the response to COVID-19, and some of the potential ways out from the pandemic. I'd like to begin also by acknowledging the traditional owners of the land upon which we're meeting here in Australia. And for me, it's the Gadigal people of the Eora Nation, and acknowledge their elders past, present and emerging. And also to acknowledge the Indigenous people of Vietnam as well. The format of today will be that we have a number of speakers who are going to share their learnings about COVID-19. At the end of the session, we're going to have a panel discussion where our speakers will have a chance to respond to questions. If you have questions during the session, please feel free to type them into the chat box and we'll try to cover them during the panel discussion. So I'm very pleased to introduce the first speaker that we have today, who is from Vietnam. Dr. Nguyen Tu Anh is the director of the Woolcock Institute of Medical Research in Vietnam. As the country director, she leads many studies into lung disease, including into COVID-19. She's a public health expert with more than 20 years experience in the design and management of health studies, and she has taught research methods, epidemiology, biostatistics and modelling at both Hanoi Medical University and Southern Cross University. And she's a leader on the Sydney Vietnam Initiative. So I'm very pleased to invite Dr. Tu Anh to share her screen and to share with us her talk about the current situation of COVID-19 in Vietnam.
Thank you, Greg. Thanks everyone to attend the webinar during the lunchtime in Vietnam. I'm going to share with you the update on the fourth outbreak of COVID-19 in Vietnam. My presentation has two parts. The first part, I will run you quickly through the epidemiological information on the outbreak in Vietnam. If we look at the very first cluster of the fourth outbreak, it started from one imported person in one northern province. The case traveled around the province and visited a crowded spots in the province, and then after that traveled to the central Vietnam, spreading the virus to hundreds of people. Some of the people developed symptoms and then later on visit the hospital in Hanoi, unintentionally spreading the virus to other patients and health workers. And then the virus slowly spreading into the community without the surveillance system detected it. And when we found out about the outbreak, it's already spread into several provinces in the north. The most severe impacted provinces, including Bắc Giang and Bắc Ninh. By today, if you look at the cumulative community transmitted cases on the graph in the left-hand side, we have around 67,000 cases in Vietnam. And the daily new community transmitted cases increasing rapidly, suggesting a start of an exponential curve of the transmission. And the actual number could be much higher due to limited testing coverage and detected the case in the community. The outbreak started in the North Province, as I mentioned before, and then when at this moment we seem to be able to control the outbreak in the North, but then the virus spread into the South Province. Ho Chi Minh City became the center of the outbreak. We hear several news on the surrounding province nearby Ho Chi Minh City with increasing number of cases, particularly Bình Dương, Đồng Tháp, Long An, and many other provinces in the south, as well as in the central Vietnam. And it seems that the outbreak coming back to the north of Vietnam with increasing number of new cases in Hanoi reported several days. So who was affected by the COVID-19 in this outbreak? If you look at the age distribution of COVID patients, you will see that the majority of people who got the infection are those at the working age. However, we also see 4,000 to 5,000 of children got the infection, as well as elderly, which I will mention in the next slide. Different provinces have different epidemiological picture of the outbreak. If we look at the Bắc Ninh province, which show on the graph in the left-hand side, you will see that the distribution of age group among COVID patients is similar to the population in the community, suggesting that the outbreak in Bắc Ninh is community transmitted outbreak. However, in Bắc Giang, most of the patients are adult and female because they got the infection in the industrial zone. So different provinces have different risk of the infection, of the transmission, suggesting a different response need to be developed. When we look at the reported death by age group in the table on the left-hand side, the majority of people die aged 50 and above, and the crude death rate among people elderly is much higher compared to the young people. The second part of my presentation will talk about the response in Vietnam. There are several actions to respond to the COVID-19, but I would like to mention 5 key actions. The first one is the government tried to test as many people as possible in the high-risk area to trace and to quarantine rapidly based on epidemiological risk of infection. However, at this outbreak, the test, trace, and quarantine is not yet faster than the spreading of the virus. The government also introduced targeted lockdown in a very high-risk area with high number of COVID patients. Mass communication of 5K still being implemented. And for Australian colleagues, 5K meaning that we need to wear masks, wash hands, keep distance from each other, report if you have risk or symptom. The fourth action is social distancing, also being introduced widely in Vietnam, but not early and not rigorously enough, not well implemented to be able to control this outbreak, partly also because of the Delta is spreading very fast. And number 5 is COVID vaccine has been started in Vietnam, however, the coverage is still low. If we look at the vaccine data, Vietnam has about 10 million doses available and distributed to different provinces. However, only 4 million doses was administered. And if you look at the map on the right-hand side, you will see that the coverage of vaccination in Vietnam is still very low compared to other countries. The majority of vaccines used in Vietnam are AstraZeneca. However, we start having Pfizer and Moderna administered in several provinces, in which Ho Chi Minh City and Hanoi, 2 biggest cities with the biggest risk of the outbreak, received the more vaccine doses. The government have a commitment with the vaccine company and vaccine provider for over 100 million doses by end of 2021, including nearly 39 million doses from COVAX facility. The Ministry of Health also purchased 61 million doses, as well as some donation from private corporations and other countries, making up a very high number of vaccines potentially available in Vietnam. However, we know that it is not easy to bring all the committed doses to Vietnam at the right time. The Ministry of Health also just issued a new regulation to add additional prioritized group for vaccination, and local vaccines is under clinical trials. In conclusion, I have few key messages from the wave is going to be the worst one so far, and we think that it is possible that COVID cases and death in Vietnam is underreported due to limited and low coverage of testing. The social distancing is the way to slow down the spreading of the virus, learning from the previous 3 waves. However, it is not easy to implement rigorously and at large scale level. It's not always be accepted by the community. Social distancing also have social and economic consequences to life of many people. Vaccination speed in Vietnam at this moment is still low compared to the virus spreading speed. And in addition to that, recent reported vaccine escape incident in the world suggesting that the use of vaccine should be strategically optimal. I think that evidence-based and multi-sectoral responses addressing multiple needs of people is urgently needed at this moment in Vietnam. And finally, there's no magic way to control this outbreak. COVID will stay with us for a while. And we need to develop a long-term adaptation plan. We need to invest and we need to implement such plan. Thank you for your attention.
Thank you very much, Dr. Tuang, for that sobering assessment of the situation in Vietnam. And I know that both Vietnam and Australia had very successful responses to COVID in the first year of the outbreak, and similarly are now both facing major challenges with the new Delta variant. And so I think that it is appropriate to hear from what's happening in Australia, where I think we are sharing some of the challenges that you've just talked about. So I'm pleased to introduce Professor Ben Murray. Professor Murray is a pediatrician who trained in South Africa and works at the Children's Hospital Westmead in Sydney as an infectious disease consultant. His primary research interest is into tuberculosis, where he has a wide range of interests, including epidemiology, strain diversity and evolution, diagnosis, prevention, treatment, and drug resistance. And he's going to talk to us today about the lessons from Australia during the COVID-19 pandemic. Thank you very much, Professor Murray.
Can I just check if people can hear me?
Yes, we can.
Thank you, Greg. To share our experience with you, but we are also humbled because we know that there are no easy answers, and we can only honestly share what we've learned along the way and what we still have to learn. So just a reminder that SARS-CoV is not the first coronavirus to have crossed the species barrier into humans. We know that there are at present 4 coronaviruses that we all know mostly as the common cold. We've also had MERS and the previous SARS virus that have transmitted into humans but have never established themselves. SARS-CoV-2, the cause of COVID-19, is the most recent introduction. I think we can now with confidence say that it has become fully established in the human population, and it's unlikely to disappear in the coming decades. Next. I don't want to dwell on the origins of SARS, but just to mention Professor Eddie Holmes from the University of Sydney, who together with Professor Zhang in China was the first to describe the whole genome of the SARS-CoV-2 virus. This was really important because it provided the sequence that was used for the preparation of the mRNA vaccines and also to develop the first PCR diagnostics. Next slide. You are all familiar with the multiple waves of infection that has spread around the world, the areas of the world that's been worst affected close to 200 million cases now globally, and probably far more than 4 million deaths, but those are the official death numbers, equating to around 2% of cases. But you can see that until now, Vietnam and Australia has been relatively spared. And we've had good policies in place to keep the virus out and to contain small outbreaks. Next. So this is an overview of the phylogenetic tree in New South Wales, which is the biggest province in Australia. The phylogenetic tree of all the COVID viruses that's been introduced and sequenced. I'll just quickly run through this first wave, which you can see the multicolor one in the early weeks or months of the epidemic. That was before we had strict border control in place. And you can see that multiple strains, all the different colors, were introduced at this time. Some of them transmitted locally, but over time, all of them were extinguished or eliminated. You can then see that there was a period when we had very few strains, and they were all gray. Gray indicate that these are single strains or small clusters identified in quarantine. So we had no community transmission for a number of months. And then the green, the second cluster, that was a strain that escaped from quarantine in Melbourne and then spread into New South Wales. And for a period of time, threatened our COVID control. But that was brought under control, as you can see, over time with quite a long tail. But by the beginning of this year, we've had that last introduction under control. And then we had, you can see, just gray cases again. But now the number of gray cases have increased. That means that there's more and more cases that were diagnosed in quarantine. Even though they were not spreading into the community, we had high numbers of people bringing the virus into the quarantine facilities. Next slide. So similar to Vietnam and other parts of the world, like the UK as well, we are now struggling with the introduction of the Delta variant. If you look on the left, the case profile, these are the 7-day averages. You can see that we've had two well-established waves, which I've just described. The first one was multiple strains. The second one was essentially the UK strain that escaped from quarantine in Melbourne. And now we've got this small third wave. Even though it looks small, it has had major impacts in our country where the majority of the population are currently in complete lockdown. Cases in New South Wales remain above 100 per day, and we are desperately trying to bring that under control. On the right-hand side, you can see the cumulative cases. The current wave is not registering very well yet, but it has had, like I said, a major socioeconomic impact. You can see that our death rate has been slightly higher than the global average, but we believe that's because many deaths globally are not counted, and also most of these deaths, similar to Vietnam, occurred among people who are older than 50 or even older than 70. That's where the majority of deaths have occurred. I just want to contrast this with the UK experience, where the UK are currently experiencing a massive third wave as well. Clearly, there's no certainty what is the right way, but the UK has had very high vaccination uptake, especially among the old and vulnerable people, where they've had more than 90 to 95% of the population vaccinated. And despite these exceptionally high rates of more than 50,000 cases per day, or up to 50,000 cases per day, the death rate has remained very low. It's 20 times lower than what they documented previously. And now we're all watching with bated breath to see what will happen. But so far, it demonstrates proof of principle that the vaccine at least provides strong protection against severe disease, even in vulnerable people. Next slide. So just to close off, I'll just quickly touch on, I think, the lessons, and these are just my own personal reflections, but I think we can say with confidence that SARS-CoV-2 is here to stay. that new variants of concern will continue to emerge, although at present we can state with confidence that our vaccines, the vaccines that's widely available and which Christine will cover in greater detail, are providing protection against all these variants at this point in time. We know that trying to achieve zero COVID, so no COVID transmission like Vietnam and Australia has done very effectively for nearly a year now, is a good short-term strategy, but it only buys us time. We cannot stay isolated forever. And vaccination is the only way out if we want to reintegrate with the world. To do that safely will require very high rates of vaccination. And both of us, both our countries are in a race against time for the vaccination to outstrip the infection, or if we can buy time with very effective social distancing measures to get our vaccination rates up as high as possible to make our populations less vulnerable. Thank you.
Thank you very much, Professor Murray. And it's been fascinating to think about the contrasts between our countries, but the shared success in the initial period. And I think also the importance of learning from the experience in other countries to make decisions about how we should proceed. So we're very fortunate to have with us as our third speaker today, Professor Christine McCartney. Professor McCartney is a pediatrician who specialises in infectious diseases and vaccinology, and she is the director of the National Centre for Immunisation Research and Surveillance, which is affiliated with the University of Sydney. And she is an infectious diseases consultant at the Children's Hospital at Westmead and a professor in the discipline of paediatrics and child health at the University of Sydney. So I'm very pleased to introduce her to speak to us about vaccines against COVID-19. What role do they play in charting a course out of the pandemic? Thank you very much, Professor McCartney.
Oh, thank you very much, Greg. And it is my pleasure to be here today. I would like to, I'll just start to share my screen and see if this is working. I think hopefully you can see my slides now.
Yes.
Great. So I would also like to acknowledge the traditional owners of the land on which we are variously meeting in Australia and the Indigenous peoples of Vietnam, and also acknowledge all colleagues on this call today from Vietnam. I know we share a lot in common, and I think it is very interesting to hear from Tuan the story of vaccination so far in Vietnam, and I would like to touch on vaccination, of course, not just in Australia, but also around the globe. So as I think everyone has discussed, the global situation continues to be very challenging, particularly with the emergence of the Delta strain and almost 200 million confirmed cases and over 4 million deaths, which is an underestimation of the total number of deaths. I believe that in the past 1 week, the number of cases has increased by more than 12%. And in our region of the Western Pacific region for WHO, cases have increased by around 30%. So I think there are many places around the world that are now finding the more transmissible Delta variant very challenging. But we do have effective and very safe vaccines. And we have now an array of these tools. Not yet enough supply, but 2 mRNA vaccines, 4 adenovirus vector-based vaccines, and around 3 inactivated vaccines, plus some others in addition to these 9 that are being used just within a country locally or produced by that country. noting, of course, that the one vaccine on the left here produced by Novavax is not yet registered or used in any country, although it has reported high efficacy in clinical trials. So in many ways, considering where we were 1 year ago when the phase 3 studies were just commencing, we are in good shape. But of course, the supplies cannot come soon enough. I thought I would just put this up to reinforce what Ben showed you, that still for Australia, we are at a relatively low vaccination rate compared to many other parts of the world. We are using AstraZeneca and Pfizer vaccines, and from September, we will have Moderna vaccine available. But our many challenges in Australia have been related to vaccine supply. Globally, you know that the World Health Organization has now approved 7 vaccines, and this is based not just on studies of vaccine efficacy, which are the results from clinical trials, but also on studies in the real world of vaccine effectiveness. And this is a slide showing some of those vaccine effectiveness studies, which have, I think, predominantly been done for Pfizer, but also a number for AstraZeneca, some now for Coronavac or Sinovac vaccine, and some for Moderna. And you can see overwhelmingly that these studies tell us that these vaccines protect more than 50% of the time. And if you look on the right-hand side, you can see that they, particularly after 2 doses, protect most importantly against severe disease and against death, which is really the thing that we want most. I think importantly, we do know that the vaccines also protect on the left-hand side against asymptomatic infection. And all studies that have been done so far that have looked at transmission, they haven't been done for all vaccines, but the vaccines also have an effect against one person transmitting the virus to another person. So as Ben said, we will not eliminate this virus from the world, but we can turn it into a milder illness through the effective use of vaccines. The challenge, of course, has been the more transmissible Delta variant. It may also cause an increased risk of hospitalisation. This is currently unclear, but it is suspected. And it needs every effort to be doubled. Just as it is double in transmission, we must double our efforts to vaccinate and use social measures. This is a very, very busy table, but it tells you about the vaccine performance against the different variants, alpha, beta, gamma and delta. And on the Delta side, it's to say that we know the vaccines still work against the Delta variant. They show strong protection. Certainly we have data so far for Pfizer, for AstraZeneca, and emerging data on some of the other vaccines to show that they protect against severe disease. They will stop our population from being hospitalised, being in intensive care or dying. And they are still effective against symptomatic infection. So we have the tools. We know that the vaccines have an overwhelmingly good safety profile. There are some rare but serious events attributed to the vaccines, such as the new blood clotting condition with AstraZeneca, but this is very rare. Likewise, myocarditis or inflammation of the heart from the mRNA vaccines is mild, and usually people recover quickly, and the benefits of the vaccine outweigh the risks, again, also with this vaccine. But yet we see the distribution of vaccines being uneven in populations in high-income countries, upper middle-income countries, and the lowest number of vaccines going to low-income countries and low-middle-income countries. The gap has closed a little bit here, and the inequity is slightly decreasing, but this is still the greatest challenge for the globe. And that is in part because, as I mentioned, wherever the virus can replicate rapidly, we will see additional new variants emerge in the future. This virus is telling us it will evolve if it gets the chance to spread at a high rate. So I think this is some comments taken from a presentation by Anne Lindstrom to the Western Pacific Region EPI TAG that tells us that the epidemiology is dynamic and uneven. The death toll does continue to increase. I apologise about the phone. I can't turn it off. It's in the distance. There is a high transmission of virus leading to the emergence of new variants, but vaccines are the tool to get us out of this pandemic, and we have them authorised. We need more quantities of vaccines. We need them to be distributed more evenly. But when countries can obtain these vaccines, we need to use them very effectively to protect our most vulnerable populations. And I think it is now a time, I am understanding from WHO, for example, that they, and from the UN Secretary Antonio Guterres, that there is a plan underway to make a global vaccination strategy now a year and a half into the pandemic. But I think it's very important for all of us as countries to work together and link up our vaccination plans and endeavour to be able to support each other in this initiative. I just wanted to emphasise the role of governments in COVID-19 vaccination, and there is this very interesting paper from the OECD which talks about some of the key messages for governments as we go forward in the pandemic. And I wanted to mention also the issue of equity, which of course is so important. It is very hard to prioritise vaccines. I think this would be a good thing to talk about in the discussion. But we know that age is by far and away the greatest risk factor for COVID-19 severe outcomes. And I've also put on this slide the guidance on developing a national deployment and vaccination plan. This is a complex undertaking, and it is really, I think, a time to examine where we have been able to get with these vaccination plans for Australia, for Vietnam, for many other countries. I just wanted to end by talking about what motivates people to vaccinate. A risk of the disease, confidence in the effectiveness and safety, trust in the process of vaccine development, which is, of course, messaged by trusted leaders and people in the community, a desire to protect vulnerable people, having role models, having trust in government and health systems, healthcare provider recommendations, and, of course, access to vaccination, that vaccination is convenient. There is a lot of work behind each of these tiles, but when we can get this right, we know we can prevent disease and severe outcomes. And this, of course, includes being able to continue our vaccination programs for children. Sadly, a recent report shows that an additional 3.7 million children missed out on routine immunisation. So whilst COVID is mainly hitting our elderly, it's also causing our young children to miss vaccination, miss education, and sometimes miss food and other critical needs. So I think it's a real call for us to work together. My key messages are that the ongoing pandemic, including the Delta variant, challenge us to roll out vaccines more effectively than ever. We have the tools to use now, and we will be able to turn this into a milder disease with them, the combination of vaccines and public health and social measures. And I also believe strongly that we can do more by learning and supporting each other. Thank you very much.
Thank you very much, Professor McCartney. And thank you everybody who's joining us online. This is a webinar which is hosted by the Sydney Vietnam Initiative. That is an initiative between the University of Sydney and our many partners and friends in Vietnam. For our next speaker, I'm pleased to introduce Mr. Michael Wiseman. He is the Assistant Secretary of the Therapeutic Goods Administration's Scientific Evaluation Branch. The TGA is Australia's national regulator of therapeutic goods, including vaccines. He has over 24 years experience working with regulatory organisations, both in Australia and Canada, and is Senior Executive Manager with day-to-day responsibility for 2 regional regulatory support programs that the Australian government is undertaking to the Pacific and Southeast Asia. It's called the Indo-Pacific Regulatory Support Program and the Australian Expert Technical Assistance Program Regulatory Support and Safety Monitoring Program. Both of these 2 programs are being implemented by the TGA in partnership with the Department of Foreign Affairs and Trade, as well as the Indo-Pacific Health Security Initiative. Thank you very much, Michael Wiseman, for joining us today.
Thanks, Greg, and good morning, good afternoon, everybody. I really appreciate the opportunity to present to you all today, and I think my main aim today is to raise your awareness of the 2 programs that Greg has just spoken about, because you may not be aware of the assistance or the offer of assistance that the Australian government, through the Therapeutic Goods Administration and other partners, has available to support our region. So the TGA, we have been supporting the region for a number of years now, including Vietnam, since 2018, when the Regional Regulatory Strengthening Program was first launched. And that program was designed, or is designed, and is delivering support to a number of countries in our region to help build the capabilities and capacities of their national regulatory authorities. And through that program, we've been able to build very good relationships and networks of regulators across the region. With the onset of the COVID-19 pandemic, the Australian government has also extended its support to the region through the development and implementation of the Australian Expert Technical Assistance Program, and has asked the TGA to further support the safe rollout of COVID vaccines to our regional partners and colleagues and countries in the Pacific and Southeast Asia. And under that program, we are specifically providing support to countries, should they wish to take us up on that support, in 4 key areas. And those key areas relate to technical input or regulatory input around procurement of different COVID-19 vaccines. We're also providing support to countries in the decision-making or the market authorisation process of vaccines that are available for supply, not underscoring the fact that supply is the #1 issue facing all countries in the world at the moment. But we're also providing support around the good manufacturing practices, and that is a key link to the supply. That is the manufacturers and the facilities that are producing the vaccines, making sure that those requirements that they are able to meet, which gives a level of assurance around the quality of the product, is very, very important. So that GMP aspect, we're providing support to countries around those assessments, as well as, importantly, the pharmacovigilance and safety monitoring of vaccines as they are rolled out across countries. And so there's those 4 key areas around decision-making for procurement, the market authorisation or product registration, good manufacturing practice, and pharmacovigilance. So I guess we have this program, this second program was only recently launched by the Australian government. So this today presents a wonderful opportunity to raise the profile of these programs and the assistance that the Australian government is offering to the region. So for those on the line who may be on the line from the National Medicines Regulator of Vietnam, or the vaccine immunisation programs, Should you wish to understand a little bit more about the program itself, please do not hesitate to contact the Therapeutic Goods Administration. Importantly, Professor McCartney's group, the NCIS, is also an important partner in this program and is available to also provide support to countries in some of the communication and surveillance and safety monitoring of vaccines as they are rolled out. I think that's all I really wanted to say today, Greg. So happy to take questions, and I might leave it there.
Thank you very much, Michael. We might save the questions for the panel discussion at the end if you're able to stay online, or people can type them into the chat as we go. But thanks very much for sharing the Australian government's contribution to vaccines throughout the region. Our final speaker for today is going to help us to explore the potential future trajectory of COVID-19. Everybody that I speak to wants to know what's going to happen next. And one of the most powerful tools that we have to answer that question is mathematical modelling. Associate Professor James Trower is an Associate Professor at Monash University. He has been head of the Epidemiological Modelling Unit for the School of Public Health and Preventive Medicine, in which role he's developed modelling tools to support policymakers and public health professionals to understand and fight infectious disease threats, including both tuberculosis and COVID-19. His modelling projects have been undertaken across the region with a wide range of partners, and he has been working on modelling for COVID-19, both for the Australian response and also in the Indo-Pacific region. So I welcome Associate Professor Trower's speech today about the topic of the path out of the pandemic. What can modelling teach us?
Thanks, Greg. And hopefully you can hear me clearly. Let me know if you can't, and you should be able to see my first slide as a full screen at the moment. That's right. And let me know if that's not the case. Thank you so much for having me. It's a privilege to be speaking to so many people across multiple countries, and I strongly agree with much of what's been presented up until now, and it's also a privilege to be on a panel with such distinguished experts in this area. So, but to get stuck into things, I guess the first thing I wanted to discuss was that I am actually relatively optimistic about the prospects in the longer term. I think I don't want to in any way downplay the level of crisis that we're currently in terms of the pandemic. I think it's a really dangerous time, and probably the most dangerous time of the pandemic so far. But just to try to put a tiny little bit of positivity into this, I think I was really interested in this article in Science, which I've put on this slide, that that I think really accords very well with a lot of things that I've been thinking throughout the pandemic about the longer term prospects for COVID control. So for the endemic circulating human coronaviruses, we have a situation in which we know that sterilizing immunity is relatively short-lived, but people do not get severe outcomes. And that's reflected in serosurveillance studies that show that the IgM, which is sort of the acute response to infection, is predominantly within the youngest individuals, whereas IgG, which is more the sort of memory response of the immune system that we can measure peripherally, reaches very high levels early in life and is maintained. And modelling from that can be used to demonstrate that the mean age of infection for most of these endemic circulating human coronaviruses, these are four endemic circulating human coronaviruses, all the mean age of infection is about 4 years. And so once you have a infection that circulates predominantly in young children, and people are exposed to it in young children for the first time, it's very likely that the mortality that we observe as a result of this infection is going to decline to very low levels. And so I think we see for COVID that we have a very similar situation to these coronaviruses. The main issue for COVID, of course, is that people of all ages have never been exposed to this before. So elderly people who are particularly vulnerable on their first exposure are much more likely to develop severe outcomes and die. So this particular group who were modelling how the infection fatality rate might change over time as circulation progressively shifts towards younger age groups. The top panel is the case of COVID, and you can see that we estimate that for the infection fatality rate, the number of deaths related to the number of deaths divided by the number of infections starts off at around 0.8%. But as we approach this endemic circulating situation, it falls about an order of magnitude. It can fall tenfold and hopefully in the longer term be less harmful. As I say, that doesn't, I think, say anything about the fact that we are currently in quite a crisis. And I wanted to talk about modelling that we've done in the region. Of course, Vietnam's in the Western Pacific region from the WHO's perspective. And the Philippines and Malaysia are two countries in the Western Pacific region that we've been working with. We've recently published our analysis of modelling that we've done for the Philippines. And we used a fully mechanistic model that was based on an SCIR framework and had a number of inputs and attempted to recreate a fairly realistic simulation of the epidemic in the Philippines. We found that we could generally, just using empiric data as inputs that were available from the Philippines, including mobility and testing rates, generally replicate the epidemic quite well. If you look at the Philippines epidemic profile over time, this is on a log scale, which might make it a little bit harder to follow, but through the middle part of last year, the Philippines had an escalating epidemic and became one of the most highly affected countries in the world. And then the epidemic began to plateau. And the data sources that we employed, that we used to calibrate the model, allowed us to capture much of this profile of the epidemic. But only once we included some other process that was going on over the course of the middle of last year. And talking to people in country, we decided that the most likely explanation was that this was micro-distancing, behavioural changes, including the use of face masks and physical distancing, that really came on board and was adopted progressively more in the Philippines over the middle part of last year. Once we included that process in the model, we could recover a very good fit to the notification data that we were trying to capture, and without that process included, we couldn't really fit the model at all. So I think that we highlighted from this paper that the micro-distancing appeared to be a very important aspect of what was going on. And so in the case of the Philippines, notifications were considered to be probably the most reliable source of data, even though mortality is often considered to be a harder source of data. For the Philippines, there'd been a lot of time and effort invested in making sure that notification data was as reliable as it could be. Whereas for ICU reporting, that only came on board progressively over the course of last year, and deaths were actually considered to be a less reliable marker in this country as well. But nevertheless, we felt that within the context of our model framework, we could recover a reasonably good simulation of all aspects of the epidemic for the Philippines once we'd included that micro-distancing process. To shift to Malaysia briefly, which is the other country that we've been working with. Malaysia had exceptionally good control for much of last year, much like Vietnam. And then through cross-border transmission in Sabah state, which borders Indonesia, had a major first wave around the start of this year, which was then controlled through lockdown measures and public health and social measures before there was another escalation in transmission, which is almost certainly attributable to the Delta variant, although the genomic epidemiology is not as solid as it might be in some higher income settings. So we were able again to capture this model, but only once, this profile of transmission and the epidemic profile, but only once we included the Delta variant emerging a couple of months ago and causing an upswing in cases. And it's also notable that the model, which doesn't consider that the variant is any more or less severe than the wild type, underfit during the major epidemic of the wild type, but then during the variant era, it overfit to notifications in particular, but the reverse for deaths. So it seems like on the ground in Malaysia and a lot of the countries we've been working with, Delta does seem to be causing a greater number of deaths, given the number of cases that we're seeing. So we used this model. We felt that it was a pretty good depiction of the current epidemiological situation, and it captured the epidemic profile reasonably well, and that it was satisfactory for projecting forward cases. For both the Philippines and Malaysia, we didn't really have the luxury of good serosurveillance data to calibrate our model to, which I think is particularly useful. But we did have these multiple data streams, and through, I guess, the processes that I've described, we're able to capture the epidemic profile broadly quite well. And so we then projected forward a number of scenario projections. So we considered what would happen under various vaccination scenarios, but the first thing to consider is that if you just project forward in the absence of any lockdowns, you get extremely high spikes in transmission, which may well be realistic in the case of Delta. It's quite scary what the virus may be capable of, and vaccination doesn't mitigate that to a significant extent. Whereas if you consider that a number of the lockdown measures and the public health and social measures remain in place into the future, if they're maintained at sort of baseline, well, the baseline level was continuing the lockdown. If they're released to a moderate degree, then we have time for the vaccination programs to get in there and to reduce the peak of the curve and to make a big difference. So I think this is really the name of the game at the moment, is that for countries that are now, for so many countries around the world that are facing this Delta wave and the potential for very high levels of cases, as Malaysia is seeing with full ICUs and significant numbers of deaths. The main objective should be to try to get as much of the population vaccinated before they're exposed for the first time. And it really is a race against time. And there's the potential to save a lot of lives by getting vaccines into people before they're infected. I'll finish there.
Great. Thank you very much, James. Much appreciated. And I think it's an example of how we can learn from other countries' experience, because the pandemic is, of course, at different stages in different places. And so lessons from countries that have much more severe outbreaks can help those who are earlier in their outbreaks to go and respond more rapidly, more effectively. So I'm now pleased to turn to a panel discussion, and I'd ask if our panel members could switch their cameras on so that we can have a discussion about some of the issues that have been raised in the chat box. So my first question will go to Dr. Tuang, who is our first speaker. And I'd like to ask Dr. Tuang, the most recent outbreak in Vietnam is due to the Delta variant. I just wondered if you could comment on how you think the Delta variant has affected the outbreak in Vietnam compared to last year, and what impact that is going to have on the future over the rest of the pandemic for Vietnam.
Thank you, Professor Greg Fox, for the question. I think that the Delta variant is clearly showing that it has very big impact on the outbreak in Vietnam. The government of Vietnam was able to control the previous 3 outbreaks quite, I should not say easily, but it is not too challenging to control the previous 3 outbreak one. But with the 4th one, it is very hard. Even when the government implement the same strategy, same action, same method, but the result has not been shown as the same as before, requiring a significant change in how we should address or how we should respond to Delta variant. And I think that at this moment, the virus, of course, spreading into the community, and it is very difficult to control and to believe that we can live with zero COVID. So in the future, coming 6 months or year or even 2 years, we have to adapt and change the plan on how we can stay together, how we can live healthy and control this variant.
Thank you, Dr. Tuang. I'm now going to ask Professor Ben Murray about testing for COVID-19. In both Australia and in Vietnam last year, testing of high-risk populations and contact tracing has enabled control of the spread of COVID-19. I wonder if you could talk to us about what you think the role of testing is once there is much more widespread transmission in the community, and how the public health system should adapt their strategies in that context.
Thank you, Greg. I should just first emphasize that similar to what Tuan said, I think the Delta variant has humbled us all. Even in New South Wales, we had a fairly firm belief that we would be able to contain the spread of the Delta variant by just doing the same things that worked for us last year, and it didn't. But a core part of the strategy, the control strategy, has been to test as many people as possible, to reduce barriers to testing access, and then to very effectively try and implement control measures linked to the testing. That is very effective when case rates are relatively low. But you are right that there's a point when the infection spread into communities where transmission chains become a lot harder to reconstruct. And that's the point where you need population level measures, which is what we have implemented in Sydney at the moment. I think throughout, even if you implement population level measures, testing is the only way that you can keep a tab of what's happening in the community. So at present, I would say, and with the Delta strain having spread quite widely in Sydney, testing is no longer providing direct guidance for the public health action. The public health action is predominantly community-based and geographically based, broad geography. But the testing gives you that important signal to see whether your measures are working and whether you should adapt the measures. I think once you have spread beyond more than 100 cases or more per day, to use testing to target your public health intervention becomes impossible. But testing remains important for that broad guiding value.
Thanks very much. I'm now going to ask a question to Professor McCartney, which is a question that's been asked by Nguyen Minh Nhat, who makes a comment that no one is safe until everyone is safe. And so she asks, what comments do you have on the issue of how we can go and vaccinate the majority of the world's population so we can truly make sure that everybody is safe?
Yeah, thank you for that question. I think it's about protecting the most vulnerable at first, because I think, and you know, as James said, we are in a race against the Delta variant now. So I think for every country, it's an absolute imperative to actually vaccinate our elderly first and our oldest people, and ideally those with, you know, also medical risk conditions. But once you start to target in a country, it can be very hard because you have to be able to reach those people and get them with the vaccine. Of course, we do want to ultimately offer the vaccine to all adults, but I think we know now that the virus will likely continue to circulate in children, and what, as I think, again, James was alluding to, we will see is that there will be an immune response develop in those who have been infected. It might be that actually repeated but mild infections in young children cause them to become immune over time, like this settles into a pattern more like a common cold. But right now, it's a deadly virus. because we all have, you know, largely, unless we've had a vaccine or we've had the virus itself, we all have no immunity. We are sitting ducks. And to build that immunity, we need, you know, vaccine, or infection, vaccine, infection, vaccine. So I think I remain optimistic as well, but I think we must prevent, as the World Health Organization has said, you know, we must more equitably prevent severe disease and death across the world. And this is where for countries that don't have high coverage yet in their older populations, and I include Australia, we are not yet there, enough coverage in our older people. We are trying very hard now, but also Vietnam, many other countries, this is particularly where to target, as I think, and I expect your prioritisation plans for each country are sitting. The plans for each country understandably are a little bit different. But in answer to the question, I think we will have to be more controlling the virus in who gets the virus and who becomes severely ill, rather than eliminating this virus because it's so hard.
Thank you. And I could just ask a follow-up question to you about how NCEARS Global is able to help support the scale-up of vaccines.
Greg, thanks very much. And I didn't want to take my speaker time, but perhaps I could very quickly share the screen and just show you very quickly how we are organised. And thank you so much to Michael Wiseman, who mentioned us. We are working closely with the Therapeutic Goods Administration, and we are funded through the Australian government, through Australian Aid, as was mentioned, under the Vaccine Access and Health Security Initiative. And the aims are there in the bubbles, but really there is an on-offer for countries in our region, the Australian technical expertise and assistance, both through our national centre that supports the Australian government and other governments in the country, provincial governments, but also the regulatory support. And just very quickly, we have the potential to do this in 18 up to 18 countries. We already have some programs going on, and you can see there that can be in support of immunisation service delivery, vaccine coverage assessment, surveillance, epidemiology, vaccine safety issues, and social and behavioural insights, I think, is a really big area. And of course, vaccine program planning. And as an example of that, we have a wonderful connection already with the country of Timor-Leste, which is to our north in Darwin, where our colleagues from Menzies have a country office. And I know that the WUCOC, led by Tuan, has a wonderful country office, you know, and presence in Vietnam. So I think when we can join with others who are already, you know, joining up to do these sorts of initiatives, this is a wonderful thing. So this is our staff member here, Sarah Sheridan, who is working with the people of Timor-Leste. Thanks very much, Greg, and please feel free to reach out, anyone who would like to talk with us more about that, and with Michael as well.
Thank you. Thanks very much. I might ask a question now to James, Associate Professor James Trower, just about the effect of emerging variants. So we've seen that the Delta variant has really changed the game in relation to the transmission and potentially the health consequences of COVID-19. The question which we had in the chat was, how likely are vaccines going to be able to outrun emerging variants? And what are some of the potentials if, for example, some of the emerging variants don't respond to vaccines as they do currently?
Right, yeah, there's quite a few things to talk about there. I mean, I think one thing, I guess, that my group has been promoting on the whole is to not think of herd immunity as a dichotomy, and because I think if you think of herd immunity as being an all or nothing thing, you you can become a bit sort of nihilistic and think that there's nothing that you can do with vaccination. And we do know that the herd immunity threshold is, of course, a lot higher with Delta because it's so much more transmissible. So it may well be that you need to get to 80 to 90% of your population covered to reach herd immunity. But I think we have to be very, very clear that that does not in any way reduce the importance of vaccination. And for Delta being more transmissible, it means that getting your first 10% of your population vaccinated is even more critical, and getting the next 10% is even more critical. So beginning to build up some population immunity is so important, even if you can only get, I don't know, 20 to 30% of your population covered with 2 doses before Delta overwhelms. It's going to save a huge number of lives. So I guess that's one point I'd make. In terms of variants, I mean, I think actually I've been relatively positive about what I've seen so far. The UK have a lot of transmission. They've got, as was mentioned by Ben, at least sort of 40 to 50,000 cases a day. And variants, there are clearly, obviously, a lot of variants emerging, but there's been convergent evolution where most of the variants have picked up similar mutations, even if they've emerged in different parts of the world, to make them more transmissible. And we haven't yet had a virus that can both sort of escape vaccines but have a very high infection fatality rate, even in countries that have high vaccine coverage like the UK and Israel, and in the UK where there's high levels of transmission. So I'm hopeful that these vaccines will be able to hold things off and continue to continue to have that effect in the UK that we've seen, where the third wave has been is getting up towards the point where it's as big as the second, and yet the deaths are just so much less than what they were in the previous wave there.
Thank you. One of the questions that's come up in our chat is just around the collaboration between science and government, that we've seen in different countries that experts have played an important role in informing government policy. And I'd just like to ask Dr. Tuang about her opinion as to how science and research can be used to inform the policy response in Vietnam.
Thank you for the question. I believe that the experts with scientific information and knowledge could be very valuable to provide advice and recommendation to the government on how to respond to the COVID pandemic. I believe that there are many experts, scientists in Vietnam who could help the government to organize, to interpret the available data in a meaningful way, to provide insight, information, and interpretation of the scale of the pandemic and effectiveness of each response strategy, as well as to provide the government evidence-based information and recommendation from around the world and countries with similar situation to Vietnam. I think that would be great if the government of Vietnam could form a group of experts to provide such recommendation on a regular basis to the government as well as to the public.
Thank you. So I'm going to ask Professor Ben Murray next about lockdown. We're in a lockdown at the moment in Sydney, and I think many people joining us from Vietnam are also in a lockdown at the moment. How long do we need to lock down for? How do we decide when it's possible to release social distancing and some of the more strict restrictions that we are under?
So Greg, I think in Australia, we've had COVID suppression formal policy for quite a while, which suggested that we would tolerate a bit of the virus in the community, not to have major economic impacts. Although the experience in the last 18 months really has shown us that even with the previous strains, suppression was not the most cost-effective strategy. As I've shown you with the data in New South Wales, if you can get rid of introductions, you can open up your society, your economy opens up again. Delta has made that imperative even stronger, that the best way to live with the virus at this point, with low rates of vaccination, is to live without the virus. So my sense is that in New South Wales, we are probably going to try and maintain the lockdown until we are confident that we can eliminate this virus. Obviously, the more time you've invested in lockdown, the more scared you become to release that lockdown too early, because otherwise you've wasted all the effort and the time without achieving the outcome that you're aiming for. So given the current risk aversion and the political climate, we will probably stay in lockdown until case numbers are under 10 to 5 per day. And we have very strong confidence that all cases are happening in quarantine and we can control the epidemic before anyone will have confidence to release or relax social constraints. In the back of this, the risk is that we focus on the elimination, which is important and buys us time. But the only way to get out of this is to ramp up vaccination as quickly as we can, so that we are in a different position if a future escape happens, or if in a few months' time we come to the conclusion that we are unable to eradicate this. We shouldn't then still have less than 20% of the population vaccinated. That will be a very bad outcome. And then we would also have wasted 3-4 months of lockdown. So we have to retain an absolute sense of urgency, because at this time, we are not 100% certain that lockdown will achieve elimination, although that remains our aim.
Thank you. And I just have one final question for Michael Wiseman from the Australian government. I just wondered if you could tell us, what role do you think partnerships between governments have in addressing the COVID crisis that we face?
Well, yeah, thanks, Greg. I think partnerships are everything, and government, this is a global problem, so a global solution's needed. And I think very much the Australian government recognises that. We as regulators, as the national regulator of Australia, we've been working incredibly closely with our global counterparts right across this pandemic. I think it's a real positive that's forced that collaboration in many ways. I just wish it didn't have the impact that it's had globally, but it has. This is where we're at. The Australian government's recognised the need, the role that the Australian government can play in supporting our neighbours. And as I think it's been mentioned many times, until this virus is eliminated globally, it's a problem for the globe. So collaboration is key. The program that the Australian government supporting with the TGA and NCIS is part of that. And again, you know, the message is please reach out if people think that the Australian government can support Vietnam. We are standing ready and willing to assist.
Thank you very much, everybody online, for their questions that they've shared. I'm sorry that we haven't had a chance to get to all of those questions, but please feel free to drop an email to us and we can try and pass them on. I'd like to, just in closing, thank a number of people for today as a part of the Sydney Vietnam Initiative. So first of all, I'd like to thank the event organisers, including Lily Sykes and Phap Ngoc Yen and Dr. Tuang from the Woolcock in Vietnam, and also to thank the University of Sydney and its partners for their support. And I'd like to again acknowledge the many people from Vietnam who have been partnering with the University of Sydney, and we look forward to working together on this as well as other shared challenges in the future. We will be posting this video on our YouTube channel, so please feel free to share that and to disseminate the findings of today's discussion. And once again, thank you to everybody who's participated today.